Good afternoon, or good morning, or perhaps good evening, depending on where you're joining us from today. I'm Ruth Niels. I'm a researcher at Mathematica and also a member of the Board of Directors of the Society for Research on Educational Effectiveness, or SREE. I want to welcome you to the very last session of SREE's virtual spring convening. In the before times, when we gathered in person for conferences, people who hung in there for the last session used to get boxed lunches or extra coffee or free conference registration, or at least they got extra praise. But today's last session, I think, doesn't require any of those inducements. It will keep you on the edge of your seat without the need for any extra coffee. We'll be hearing from three distinguished researchers who are conducting studies of the use of research evidence. Specifically, in these studies, they're testing the effects of different strategies for promoting the use of research evidence in educational and clinical settings. In different ways, they're seeking answers to a broad question. What kinds of supports, relationships, or systems can make a difference in whether and how practitioners incorporate research evidence into their work? This question acknowledges what we in the SREE community have come to understand more clearly over the past few years. And that is that researchers cannot take for granted that their research will be accessed or read, much less acted on or incorporated into everyday work routines. From national surveys of education leaders and detailed case studies, we have learned more about where educators obtain research, how and when they use it, and their preferred reporting formats. And at previous SREE conferences, we have discussed how researchers might modify how they do their work and what they produce in light of findings from these important descriptive studies. We are delighted to welcome these researchers to this SREE conference because we think they can push our collective thinking a bit farther by helping us understand how they came to undertake their studies, what they are testing, how they designed their studies to rigorously test strategies for promoting research use, and what they are learning from their work. We'll first hear from Dr. Aubyn Stahmer. Dr. Stahmer is a professor of psychiatry and behavioral science at UC Davis and director of community-based treatment research at the UC Davis Mind Institute. Her research focuses on examining use of evidence-based interventions for children with autism and their families in school and community settings. Next, we'll hear from Dr. Kimberly, Becker, and Dr. Bruce Chorpita, who will describe the logic behind coordinated knowledge systems and the particular system they are testing in the context of school mental health services. Dr. Kimberly Becker is an associate professor in the Department of Psychology at the University of South Carolina. She is a clinical psychologist whose research focuses on extending the research of effective psychosocial interventions with specific interests in clinical decision-making and treatment engagement. Dr. Bruce Chorpita is a professor of psychology at the University of California, Los Angeles. The aim of Dr. Chorpita's work has been to advance the effectiveness of current mental health practice technologies for children and adolescents. After the presentations, our discussant, Dr. Adam Gamoran, president of the William T. Grant Foundation, will provide remarks drawing out key points for the education research field to consider. And then we will have plenty of time for questions and answers and discussion. So finally, on behalf of the SREE board and the SREE community, I would like to thank the William T. Grant Foundation for supporting this webinar. As you may know, the foundation has had a key role in advancing knowledge about research use, including supporting rigorous studies of research use in a range of fields. This webinar is one of a series that's being offered by SREE and is supported by the foundation. The series began a few weeks ago with a fantastic session led by Dr. Vivian Singh, who talked about what we know from research on research use and what we still need to learn. SREE is planning additional webinars this spring on research use, so please stay tuned for more information about them. And so with that, let's begin the presentations, starting with Dr. Aubyn Stahmer.
Good afternoon and good morning. Thank you for having me. I'm going to talk a little bit about a brand new study and how we got here and look at the role of understanding research and implementation of autism interventions. I want to thank my co-PI, Lauren Berkman-Frazee, and our UCLA partner, Anna Lau, as well as our team members who supported some of the analyses I'll share with you today. All right. So as you may know, autism spectrum disorders has really increased. We have seen more and more children entering schools who are the primary provider of services for students with autism. And we have a kind of cadre of evidence-based practices. A most recent report in 2020 has about 28 different practices that are evidence-based for this population of children, and yet we are seeing a really large gap in the use of those practices in schools. And so that's where our work has focused in figuring out how to make these interventions applicable to community settings, including schools. I'm going to start by telling you a little bit about the work that got us to trying to learn more about understanding the use of research evidence, and then about our study that W2 Grant is helping us with, that we'll be starting. We just started this month. And so we had two separate trials that were going on at the same time, one in schools funded by IES and one in public mental health settings funded by the National Institute of Mental Health. And these were just separate studies that were in public settings, looking at adapting evidence-based practices collaboratively with the providers in that setting. And we found, my colleague, Dr. Berkman-Frazee, and I found incredibly similar results, where about 2/3 of the about 100 and little over 100 providers in each setting were learning the strategies to fidelity and completing the training program, which we thought was remarkably similar. And we wanted to see if there were supports we could put in place to improve those numbers and make them more consistent and sustainable over time, because those were challenges. So we are currently working on 2 independent linked R01s from the National Institute of Mental Health, where we are studying some implementation processes. So we looked across the data for both of these studies, and we found a couple of things that were very consistently getting in the way of people using these evidence-based strategies in their programs. And the one I'm going to focus on today is leadership support, because that is where we're seeing some real differences and what led us to this wanting to do a little bit more about understanding research. And so for leadership support, we're testing the use of something called the Teams Leadership Institute that has been based on the leadership work of Greg Ahrens and Mark Earhart, where we use an assessment of implementation climate, which you can see there, educational supports and focus, recognition of the use of evidence-based practices, and implementation leadership, how proactive and knowledgeable are leaders at supporting providers and using evidence-based practices. We do an 360 assessment of the use of these strategies, and we use that to work with the leaders in the school district to set goals for how they're going to help their teachers learn and use the strategies. For example, how are they going to make sure everyone has a copy of the manual? Who is going to check fidelity of implementation ongoing when the research study is done? How are they going to recognize teachers who are using the strategies well? Those kinds of things. This is a process we've been using to provide about a 4-hour workshop that uses the data from the 360 assessment to set goals, and then check-in calls every other week with that leadership team for about 15 to 20 minutes. And we have in our first 2 cohorts, our 3rd cohort has been a little disrupted by a pandemic, so I'm going to share the data from just the first 2. About 50 leaders in 20 different programs have gone through. We see about 2 or 3 leaders in teams in each program, which we actually weren't expecting based on the earlier use of these strategies. They usually set about 5 goals and talk with their coach around 8 or 9 times, for about 20 minutes a time. And one of the interesting things that we found, I'm just going to show just a touch of data, is if we look over here, this is what measuring the number of implementation support strategies that they use from the perspective of the teachers or the clinicians. So not the leader themselves. How are they providing this recognition and support, and how are they doing it? And you can see the group that is getting the leadership intervention is using more of this we do this in about a 6-month period of training. They're using more of those strategies, statistically significant with this small preliminary data set after they receive the leadership training. So we think there's some promise for this leadership training. The interesting thing, I think, for the school folks is that consistently on every implementation measure, schools are not doing as well in terms of having good implementation climate and leadership as clinics are. Nobody's doing great, but schools are having more significant challenges, and oftentimes we're getting schools to where the clinics are starting. So I think as we're looking at using the research evidence in school settings, we also have to look at that context and how we are supporting those strategies. So now that we're getting toward the end of this study, we're finding that the leaders really enjoy having this institute and working together to try to integrate things. They have said that they really want more information about evidence-based practices more generally. So in our case, we've had one specific practice. They did not have to think very hard about which practice that was going to be. We said, we have this to offer you. And at the end of the 6 months, when we start talking about sustainment, they are saying, we want to learn more about how we can support our teachers in using evidence-based interventions more broadly, and how we can build on what we've learned about implementing this specific practice as we're moving forward to support our students. So they're asking questions like, we've got trained in this evidence-based intervention. We're thinking about sustaining it. Is it working in our district? Should we continue to support it? They're putting resources toward this. Should we continue to do that? What other interventions or strategies do we need to support our students, both our students with autism, as well as other students, either in special education or in general education? And so the question then becomes, how to identify what those new research-informed interventions are. So this is where we have been ending up at the end of our cohorts, and that is where we turned to WT Grant to think about how we could support our school-based and clinic-based partners in using research evidence more broadly, because we were actually really excited that the research training that we did got them excited about more research evidence. They weren't just saying, great, this is over. They were saying, how can we do more? So we're thinking with this new project about how we can provide specific training and how to use research evidence more broadly to increase absorptive capacity, which really means increasing leaders' ability to locate, identify, value, and acquire different knowledge related to the use of research evidence. So we want to help them understand how to use the research literature as well as evidence from their own programs to determine whether to adopt a new practice or to sustain an ongoing practice. And so this yellow box is sort of our phase that we're looking at now after we've finished this practice sort of going through how to implement a particular evidence-based practice. And so our framework for this is really thinking about what's the best evidence available for students. And in our case, we're really focusing on students with autism. What resources, including the expertise of their teachers and clinicians, do they already have? And what are the characteristics of their students? And so because the particular evidence-based practice they might want to use will likely vary depending on the students. And then we also really, in our context, want to think about the organizational context, especially because we are seeing differences in that context across community clinics versus schools, including school mental health. And so we are in the process, and I say process like yesterday, we started thinking about doing some recruitment in gathering together a community team of leaders who participated in our trials and who will help us develop this module of our Teams Leadership Institute to help leaders understand how to access research, decide if it's relevant and applicable to their programs, how to communicate, because that's one of the things that we really found to be very important in the Leadership Institute. Leaders are doing a lot of things that they feel is really supporting the use of evidence-based practices. Teachers have no idea any of these things are happening, and so they are not feeling supported. And so that communication is really a key piece of what we're training. Also thinking about how to use local evidence about how well teachers are using different practices and how well it's working for their students. This is really important for sustainment because we know that teachers and other practitioners are going to use practices more based on the evidence that they see in front of them with their students than based on the research literature. And then thinking about how we can develop a plan for integrating the use of research evidence ongoing into their programs. And so our tools are going to be a self-assessment of the use of research evidence. That's what we started with TLI, and we think that the use of that data helps them understand how important data can be, as well as gives us a sense of what their context is like. So we'll use a self-assessment tool to determine how they're already using research evidence, and that will help us understand what those leaders need to learn. We'll help them use autism-specific EBI registries. There are some very nice registries that summarize the evidence already and make it more attainable for leaders and practitioners. And some of them also include very nice training tools in different interventions, fidelity tools, things like that. So we'll teach them how to use those tools as well as the broader literature. And then we'll think about the development of local data collection strategies, about how people are using the different interventions, how they might be adapting them, and whether that is consistent with the key ingredients of those interventions, and whether it's not. And then how they can develop plans that are proactive for implementing new strategies and sustaining them over time. And so the way we have set up our study design in thinking about the mechanisms, if we've got this use of research evidence module that I really just described to you as much as I can, because we're really going to develop that in collaboration with our partners. And we're hoping that the use of that training and those measures will change absorptive capacity and how they're acquiring, assimilating, transforming, and applying this research evidence, with a goal of changing the provider perceptions of the use of these strategies in their organization. So we want this to be not just the leader's perception of how well they're using research evidence, but those teachers and clinicians to see that their organization is valuing and using research evidence more often, and as well as local data, so that they understand that their gathering of that local data is very important. We think this will be moderated by participation in the Teams Leadership Institute. So our sample is going to be the 60 plus, we'll draw from the 60 plus districts and clinics that participated in the two trials I just told you about. And half of them participated in the Leadership Institute and half did not. So that will allow us to take a look at whether this sort of practice, implementing an evidence-based intervention and the training in implementation, climate, and leadership, how that affects their use of research evidence and their understanding how to put that into place. And then, as I mentioned, we really think whether they're in a school or a mental health system makes a difference. And so we are using what is called a step wedge design to test this intervention. We will be randomizing our 12 programs a year across schools and clinics, again, drawing from the 60 that we have enrolled, and randomizing them to a cohort 1, 2, or 3. So during this first year, as we develop our use of research evidence module and training, we are also following each of these programs and providing measures of absorptive capacity, the beginning and end of a school year. And we are looking at what they're doing to sustain these practices now that our trial has ended and they are on their own with their evidence-based practice. So we're just monitoring what they're doing. And so then in the second year, our first group of 12 programs and districts will receive this training. We'll again follow their absorptive capacity and how their providers are seeing these changes. And while we're still monitoring cohorts 2 and 3, year 3, we will start with cohort 2 and so on. And then for cohorts 1 and 2, we'll also follow them for a year past the training to see how this affects sustainment. And we'll be able to compare that with sustainment of our initial evidence-based practices that we saw in the first years of the study. So the randomization of everyone gets recruited in year 1 and randomized. And some folks are just waiting a little while for training. And so we're hoping that this training will increase the effective use of evidence-based interventions in public systems, including schools, and that there will be more systematic and clear decision-making about which evidence-based practice to use, rather than the current strategy of kind of sending teachers to in-services and hoping that things last and are done well, and that schools will have a plan for how they're going to manage and sustain different practices, as well as to decide if they're working for their programs and whether the resources should be put in place to sustain them. So we'll help them use their local data that they're taking on children's progress and teachers' use of strategies to make those decisions about sustainment and when they need to choose new ones. And so my final slide, I just want to thank our very large teams of researchers, leaders, therapists, teachers, and families who have participated in these ongoing studies that got us to this point. We've had over 140 staff members working on our 2 trials and really supporting these data, and will continue to support us as we move into this new sustainment phase of helping these programs use research evidence more systematically. So thank you. I look forward to the data that we're going to see in our next presentation and our discussion in a little bit.
Thank you, Aubyn. And now we're going to turn it over to Ruth Chorpita and Kimberly Becker to talk about their intervention and study.
Well, thank you. We work in children's mental health across populations and settings, and we help therapists use research evidence and other forms of evidence to help children and families overcome mental health challenges and live their best lives. Now, there is no shortage of evidence about what works in mental health services, yet the majority of mental health services that are delivered would not be considered evidence-based. And so the question is, why is research evidence not widely used in clinical practice?
Some of that has to do with how evidence is organized. And so what I'm showing here is a model that we've adapted from Ian Graham that talks about phases of evidence. And you see it's organized in a funnel shape with raw evidence at the top. So basically raw research studies, things that most people don't even have time to read. And then progressing through that funnel, we can organize evidence into syntheses like practice guidelines, registries, clearinghouses, and things like that. And then down at the bottom of the funnel, we can organize evidence into appliances and tools. So treatment manuals are an example of a tool. What we're going to talk about today is actually more of an appliance, which and how is that different? It's really talking about not picking off one slice of the evidence base in a manual, but imagine an appliance that could say, let's take everything in the evidence base and make it relevant to you, much more like in the way like SREE works on your phone. So anything that's out there in the research, we have an appliance to answer a question that's relevant to your situation. So those things are coming, and we're going to give you an example of one today. But the other piece of this is not just about how evidence is organized, but it has to do with situating the use of those appliances within a specific flow. And there are many flows or cycles in terms of knowledge to action. You've maybe heard of PDSA cycles or Deming cycles. Graham calls it the action cycle. And they can have many steps in them, like between 10 and 15. For today, we're going to simplify this into 4 steps. They're fairly intuitive. To use research evidence, of course, you need to first think about what is the problem that you're dealing with. You then go to this sort of selection and planning phase of figuring out what is it that you want to do about the problem. You apply a specific solution or practice to the problem, and then you monitor the outcome. And so this appliance piece really has to do with embedding your evidence resource into this flow.
Now, our specific aim was to increase the use of research evidence in the context of low treatment engagement in school mental health services. Now, engagement relates to somebody's connectedness to therapy, and low engagement is a huge problem in treatment. More than half of young people enrolled in services drop out early, usually within the first few appointments. So we created tools to support therapists' use of research evidence at each step of the action cycle. And we designed these tools based on our prior study of how therapists typically make decisions about how to support youth and families who experience low treatment engagement. We tested these tools in the context of a randomized controlled trial. We packaged these tools together in a knowledge appliance we referred to as the CKS. We called it Reaching Families when we talked to our community providers. We tested them against practice guidelines, which is a typical way of packaging evidence in mental health services. And we worked with school-based mental health providers in Los Angeles, California, and in multiple rural sites in South Carolina. Now, these areas both represent financially distressed communities and racial diversity across the sites. But we chose them because they were very different sites in terms of their resources for mental health services and their prior experience with using research evidence, with Los Angeles being a high-resourced and high-experienced site, and South Carolina being relatively low-resourced and less experienced with using research evidence. We partnered with a large group of mental health therapists and their supervisors. These are some photos from our trainings where we worked hard, but also took some fun breaks with our community partners. Now, you might wonder why we worked with supervisors when mental health therapists are the primary interventionists, and they might be the people who would be most likely to make choices about using research evidence or not. Now, we had a choice about how to constrain the action cycle, and it's certainly true that a therapist could use the CKS resources on their own. But based on some great suggestions from the William T. Grant Foundation, we built the action cycle around the naturally occurring process of supervision, where a therapist and supervisor meet together to discuss treatment cases.
So let's get to talking about the trial itself. So this Reaching Families trial was a cluster randomized trial with 34 supervisor teams and their 118 therapists whom they supervised, randomized to those 2 conditions. As Kim mentioned, this was performed at 2 different sites. In terms of the students, we screened over 1,300 student cases across the 2 sites, and about half of those were found to be at risk for dropping out of their mental health treatment. Based on school calendar and so forth, about 550 or so were eligible, and a large portion of those were invited, and 231 of those invited consented to participate in the trial. This produced an enormous data yield for this trial. So we documented over 1,200 clinical study events, so supervision and treatment events as part of this trial. More than 1,000 of those we transcribed, translated, many of them were in Spanish, and then coded them or double coded them for content. And we're still in the process. We've been doing that data processing for about a year now. We're still in the process of finishing that up, and we have about 20,000 excerpted components of those events so far, and we've applied over 36,000 unique codes to this data set. And so The challenge now is in about 5 minutes, we're going to try to show you about 30,000 data values in a single graph and see if we can make sense of that. So here we go. Now, first, we want to just go back to this action cycle so we can understand how the findings are organized. Remember those phases or those steps, rather, assessing the problem, planning the practice, applying the practice. We're going to pick those 3 off and just line them up into a flow. Okay, so we have a sequence here. And as I mentioned before, these can break down into smaller steps. So let's think about assessing the problem. We first have to consider what are the problems we might want to work on. So in this case, you might think, do I want to work on fixing is it the relationship that's not going well? And that's why this student's at risk for dropping out, or maybe they don't understand what therapy is about, right? So you can consider possible problems, and then you select one that you decide you want to work on. And then in the planning phase, you might consider what are all the possible ways I could fix that problem. And then finally select one that you intend to use with that student. And then that intent becomes the application of the practice when you meet with that student. So these steps in the action cycle, they organize themselves, as Kim pointed out, in the context of supervision. So most of this assessing and planning happens in supervision, or is supposed to happen in supervision. And then the application of that practice happens in treatment. So that's our 5 steps that we're going to look at today. And we're going to present this in terms of the 2 conditions. So you can see that CKS condition, that was our training group, our big training group in the trial. And then the practice guidelines group was our control group. So I'm going to present these findings in terms of a tree, and we're going to build it from left to right and watch how the different groups started branching off into different pathways. So what are those pathways? There's really 3. That white color or no color there is going to refer to someone simply not performing the steps. So, for example, you might not consider any of the child's problems while you're in supervision. You would get a white branch in the tree. If you're considering problems that are not relevant to the focus of the study and what you know the child has a problem with, that's a yellow branch, so not engagement-focused activities. And then if you're on target, to the extent that you're thinking about an engagement problem and the evidence base for engagement, that gets a green branch. So those are the branches. Obviously, green is the thing we're looking for here. And let's watch how this unfolds as we move left to right. So in supervision, right away, we see a difference between the 2 groups, where 100% of our coordinated knowledge system group is considering engagement problems, whereas only 68% in the practice guidelines group are thinking about engagement problems in supervision. And they've already broken off into 3 branches there. At the next step, again, 100% of our trained group ended up selecting an engagement problem they wanted to work on with their student, whereas we see only 43% of the practice guidelines group selected an engagement problem. So again, people are falling off the path at each step in this cycle. As we move to planning practices, so what do we want to do about the problem? Again, we see the same kind of branching and dropping off. So 91% of people in the CCAS group were considering some evidence-based practice for engagement, whereas only 21% in our control group were considering that. And as you can see, they're spread out now across multiple branches too. So there are different ways that they arrived at those that's not quite uniform. And then finally, in making the plan, let's pick what are we going to do? Let's select an evidence-based practice of some kind to use in our treatment session. And what you can see here is 89% of the CKS group picking an evidence-based procedure of some kind from the literature as part of their plan, as opposed to only 18% in the practice guidelines group. And one thing I wanted to point out, so I'm mentioning the branch count here too. The CKS not only kept people referencing the entire evidence base on engagement, youth engagement more successfully, but it was responsible for a lot of uniformity, right? There's most participants in that top section of this graph are really within one branch, whereas you see 26 different branches occurring, really meaning that that everybody had sort of a different history in arriving at their plan in a much more disorganized way. The other pattern you'll see is that there's been drop off at every step of the way in the practice guidelines group, where increasingly people are sort of drifting away from considering the evidence base. So I'm sure you're all excited to hear what happened in treatment, right? So how does supervision relate to treatment? And Kim's going to tell us about that.
Okay. Well, these data are hot off the presses. I think some of our students are here today to find out what's going on in treatment as well. So you might have expected to see even less green, representing a reduced focus on engagement, even into treatment. But this is not the case. In CKS, 89% of practices were engagement focused. Now we see a dramatic rise in the practice guidelines condition, where 72% of the practices focused on engagement. And I want to offer three possible explanations for these unexpected findings. So first, there's more time in treatment to apply research evidence in the form of a practice within one step of the action cycle relative to the many steps that people need to go through in supervision in the action cycle. So more time. The second thing is that by design, our measure of practice application was more sensitive to engagement practices during treatment sessions than was our measure of practice planning that occurred in supervision. So what we're presenting here represents a lower threshold in treatment than in supervision. Now, those two explanations aside, a really important consideration is the possibility that a therapist knows an evidence-based practice for engagement, any practice, and uses it in treatment. And for treatment engagement, it is highly likely that just by virtue of being a therapist, someone is supportive or encouraging, and therefore does something that appears engagement focused as we're coding these sessions. So they would appear to be using research evidence. Now, this is important because we're not just interested in use of research evidence, but we are interested in high quality use of research evidence, which we define by matching the practice, the engagement practice, to the problem that was selected in supervision. Now, why is matching important? Well, there's an evidence base that says that some practices are better suited for certain problems than are other practices. So as an example, we've all gotten appointment reminders, and appointment reminders might be helpful to people who forget an appointment is coming up or schedule two things at the same time. But appointment reminders are not helpful at reducing stigma related to therapy or helping somebody better understand what therapy involves. So we are going to look at some data coming up. Look for the dark green shading that shows when the practice, the engagement practice, matched the problem. All right. So in the CKS condition, more than 70% of the practices considered and selected matched the problem, whereas only 1% did so in the practice guidelines condition. This is really outstanding. And the reason we are so excited is that supervision, that CKS intervention, is a very light touch intervention. It is a 15 to 20 minute conversation, and it resulted in a 70-fold increase in making plans that are evidence-based. Now let's see what happens in treatment. And this deserves some fanfare as well. So we've got 47% of practices that were delivered matched the problem, and that never occurred in the practice guidelines condition. This is fantastic and beyond what we expected. Now, there are two really important points from this slide. First, use of research evidence is not the same as high quality use of research evidence. That is the dark green relative to the light green shading. But the second point is perhaps even more important, and that is that treatment is an entirely different event into which we did not introduce any structures for use of research evidence. What happened during that 15-minute CKS conversation in supervision mattered days later to what happened in treatment.
So I'm glad Kim said that, because you might have been tempted to conclude earlier supervision doesn't matter when you first saw that big improvement or the size of the green bars and so forth. but it really does seem to matter quite a bit. And I want to point out a couple more things here that we can take away from this before we wrap up. And that has to do with the specific patterns we see. So I guess what I want to say is when we think about use of research evidence, what we're really excited about is it's not all or nothing. You used research evidence or you didn't, but it's a bit more like horseshoes. We're really interested in people who got very close and maybe at the last minute something went wrong. So I want to point out two quick patterns here. We were able to keep track of the plans that people made. So I've just kind of marked that in red, whether they actually did their plan in treatment. So what's funny is actually a fraction of everybody, a small fraction of people actually stuck to the plan that they had made. So what did we make of that? You can see there's higher rates of people following their own plan in the CKS group. But what we make of that is that there's two specific kinds of opportunities. One of them is here, which is you can see that these are folks who used an engagement procedure, but it didn't match the student's problem according to the evidence base. So they simply didn't follow their own excellent plan, right? If you look to the left, it's dark green, and then as they move over to treatment, it's light green. So they made a high quality research-based plan and simply didn't follow it. That's a very easily correctable kind of thing. And then we know there's this other group that actually did follow their plan, but their plan was close, but it didn't match the child's problem. So that's another, just one little step to correct. So some low-hanging fruit, really, of people very close to getting success. If we were to fix those two issues, that would then represent an 86% versus a 0% in the bottom group. So not only are we excited about the 47%, but we're feeling like we now have a lens to be able to move that needle quite a bit. So we're going to wrap things up.
Yep. In terms of our take-home points, so we can substantially increase use of research evidence in this context, and it's facilitated through better appliance design that packages multiple and relevant evidence resources in a single, easy-to-use and useful package. It's also facilitated through connecting with workflow and social processes. So we leveraged the natural social structure of supervision and found that the upstream behaviors in supervision mattered greatly to the downstream behaviors in treatment. And other factors are often identified as possible influences on use of research evidence. So things like personal preferences and attitudes or organizational characteristics. And we didn't go into these for the sake of time. But what we found is that structuring the microsocial ecology and the working environment of the people, the therapist and the supervisor, seemed to be more important than those more distal influences.
The other big take-home point here is that our metrics, our ability to look with a finer lens at use of research evidence is really going to open up some exciting new developments. This panel here, I don't expect anybody to zoom in that closely and see what we have here, but that top tile there is actually a formal ontology built out in Protégé to refer to URE constructs, and then that second tile is our qualitative coding system software to map those excerpts onto those constructs. So we're really talking about coming up with a highly generalized model, whether it's in mental health or whether it's in education, of mapping specific URE constructs out of almost any kind of event or document. And it allows us to model this reasoning over time, as you saw, which really opens up possibilities for, pragmatic opportunities for saying, these are things we can fix, regardless of the evidence-based programs or even the problem domain that you're working in. We think this is really going to facilitate the development of better strategies for use of research evidence. So we will stop there for today, and I just want to thank all the folks who participated. These are our research team on the lower right, and then on the left there is our leadership team from South Carolina, and then the top is our provider team from Los Angeles. And I also really want to thank our sponsor, William T. Grant, who has worked with us for 4 years on these ideas, and it's been the most enriching and collaborative experience I've ever had in terms of managing a grant and discovering things together. So we're both really grateful.
Thank you so much, Bruce and Kimberly and Aubyn, for those thought-provoking presentations. I think there will be a lot to talk about. We'll have a lot to talk about between now and 1:30. I'm going to turn this over now to Adam Gamoran for some remarks.
Thank you, Ruth. And thank you to Aubyn, Bruce, and Kimberly for those fantastic remarks. There's a lot of discussion about flow, and I'm sure all of our minds are flowing with thoughts on how to apply these studies and their findings to education systems and education research. So I'd like to share my thoughts to get the conversation going. As Ruth noted in her introduction, the William T. Grant Foundation supports a portfolio of research on improving the use of research evidence in policy and practice. We've worked in this space since 2009, but in 2015, we revamped our call to emphasize development of robust strategies for getting evidence used. We also raised the cap for funding for experimental trials such as these two to $1 million. And both of these teams have been funded under that opportunity. And if you follow the William T. Grant Foundation on Twitter, we just tweeted out a link to our funding opportunity. And I know that SREE will put that link in the chat. Under the general mission of supporting research to improve the lives of young people, we reasoned it's not going to improve the lives of young people if we support the research and the findings just sit on the shelves of a university library. We need to see how research is used. And this is not just about disseminating research, telling people what the findings are. It's about getting the research used and building strategies to improve that use. It's so important to bring this message to the Society for Research on Educational Effectiveness, a professional society with the mission of identifying effective practices and policies in education. SREE was born out of the new education sciences, the efforts at the Institute of Education Sciences under Russ Whitehurst to support research on what works in education, to raise learning, to reduce gaps, to improve children's social and emotional outcomes, to advance educational attainment, and so on. Over time, IES and the new education sciences have become more sophisticated. So it's not just what works, but it's what works for whom and under what circumstances. But it's still a long way from asking and answering those questions to actually getting evidence used to inform decisions. And SREE has been a leader in promoting the realization and featuring work on conditions that lead to evidence use, given the existence of credible evidence on some topic. Now, within the realm of education, a leading strategy for promoting the use of education, of evidence in education, has been the research practice partnership. We are seeing those spring up all over the country in major school districts and at the state level. And the reasoning here is that evidence use is not just about producing credible evidence, it's about developing relationships between producers and consumers of evidence and the intermediaries who knit them together. And once those relationships are developed, then there's trust, there's opportunity for flow of questions both ways and for flow of information in both ways. And so that enhances the chances that evidence will get used. But today, we are seeing an alternative to the research practice partnership strategy. Instead, we are seeing in both of these presentations, body of knowledge that is coordinated and curated, that is brought into a training context, and that leads to the development of routines so that in everyday practice, there's an entry point for the use of evidence from research. Now, the research practice partnership idea is all about creating structures to build relationships. And note here that in both of the presentations we had today, structures are also extremely important. Kimberly mentioned the microecology of relationships between the evidence use, the training, the supervision, and ultimately the treatment practices. So structuring these relationships and infusing them with evidence from research is the key to these robust strategies for getting evidence used. Now, education researchers like Cynthia Coburn and Caitlin Farrell have shown the importance of absorptive capacity for school districts in whether or not evidence gets used. Absorptive capacity is a term that came out of business research in the 1990s, noting that very often businesses lack the ability to bring in new knowledge because they're so busy just handling their day-to-day work. And how much more so does that apply to school districts, as researchers like Coburn and Farrell have shown? School districts, and for that matter, state education agencies, are so caught up in the day-to-day requirements of just keeping the trains running that they don't have a capacity to bring in new knowledge from research or elsewhere and to bring it to training opportunities and ultimately build it into the routines of practice. So Aubyn Stahmer's study takes on that challenge because she asks, how can we build that absorptive capacity into these structures? And she shows through this process of knowledge curation and training that it is possible to expand the absorptive capacity, or at least that's the hypothesis for the new work, to expand the absorptive capacity so that new knowledge can come in and become prevalent in everyday practices. Now, at the beginning of Bruce and Kimberly's presentation, they mentioned that there have been over 700 randomized control trials of over 800 interventions in mental health. Well, I challenge anyone, any practitioner in any clearinghouse in the world to sift through those 700 trials of 800 interventions and figure out which one to use on Tuesday to improve the mental health engagement of their students. It can't be done. No one has the absorptive capacity for that, and no system has that absorptive capacity. What we need instead is a robust strategy to curate that knowledge, to map it on to specific problems, to bring a training capacity, to have supervisors work with practitioners so that ultimately that kind of practice will become part of daily routines. And you've seen in this example of the coordinated knowledge system that the effects can be massive, that there is a huge shift in the extent to which planning occurs, in the extent to which implementation of plans occur, and perhaps most importantly, as Kimberly showed at the end, in the way those treatment strategies are matched to the specific problems of engaging young people in their mental health therapy. And so this kind of approach is a strategy that can be implemented and tested through a randomized design. Just what SREE members excel at. So I hope we will take away that these designs can be applied in more domains of education than just mental health. What we need in education research, oh, and by the way, both of the presentations today focus on the use of research in practice. We're also interested in the use of research in policy, and that no doubt requires different kinds of interventions. Here, the focus is on using evidence to improve day-to-day practice and treatment. So what do we need in education research? We need robust strategies to get evidence used. That means tools to organize knowledge. It means training, and it means structuring the microecology of teaching practices and other practices within education to foment the use of evidence. Now, that could include research practice partnerships. Research practice partnerships might provide an effective framework for building and implementing those robust strategies, but it's more than simply building a relationship over generalized issues. It's about addressing specific topics with evidence. Also, it could involve the conceptual use of research evidence. So in these examples, we focused on instrumental use, when there's a problem to be solved and evidence to bear on it. But in education, a lot of the use of evidence is conceptual, and that could be examined as well. A knowledge system could help practitioners think about the problems they confront in new ways without necessarily influencing a particular decision. At the system level, the level of the school district, and perhaps the state agency as well, expanding the absorptive capacity, the ability to bring in knowledge and apply it, is a crucial bottleneck towards getting evidence used. And we need more research, not just on identifying and describing the bottleneck, but showing how those bottlenecks can be blown up, and so the knowledge can flow through and the questions can flow back. There are also implications for training of educational leaders. Finally, what do we need of SREE members? What do we need of you who are listening to this webinar? Well, we need you to apply your penchant for causal analysis to the question of robust strategies to get evidence used. Of course, there's a lot of development work that needs to be undertaken before we can get to that point, but ultimately answering questions about how to actually improve the use of research evidence, to use observed measures of the use of research evidence, such as you saw in this study, not just self-reports, but observed measures of the use of research evidence, and testing their prevalence through these strategies is an agenda for SREE membership in the future. Thank you.
All right, thank you, Adam. We do have lots of time, as promised, for discussion, for questions and answers. So I don't see any yet. So while we are waiting for people to be a little less shy, I will kick off with some questions, and that'll maybe give you an opportunity to think about what you want to ask of our distinguished guests. So the first question is for Aubyn, and I'm wondering, Aubyn, can you talk a little bit about how you think the initial leadership training that you discussed might affect leaders' uptake of the use of research evidence training? You talked about these two different trainings.
Absolutely. So the leadership training that we did, I think, gave leaders in that group some understanding of the kind of supports that they could provide their teachers that really help them continue to use evidence-based practice. For example, even just having the manuals available often wasn't the case, or the leader, we had, for the first time ever in the leadership group, principals come to parts of the training so that they understood what to look for if they walk through a teacher's classroom, to look for the evidence-based practice and see how it's going so they could say, great work, things like that. And I think that understanding of the kind of supports teachers need and the benefit, which also gave them some understanding of the benefits of the training and the use of the evidence-based practice, in the importance of the fidelity to the practice, help them be sort of primed for wanting to learn more about research evidence. In the other group, we had contact with the leaders, but they weren't as sophisticated in the kinds of questions they were asking about what's next, what can we learn more about. And so I think that initial training about the importance of their role as a leader in the use of evidence in their school will give them some sort of more eagerness about the use of research evidence. Hopefully the training itself will also give that to the other group, but I think the training group will come in ready to go.
All right, that's great. Let me ask you just one more question, and it's a question about context, and then I'll move on to the other team if we don't have any other additional questions here. Also with a question about sort of context and research use. Does your team, Aubyn, have any thoughts about why the implementation climate in community clinics is stronger than it is in schools?
Yeah, it's so interesting what Bruce and Kim were talking about in terms of supervision and the finding that the context might not be as important. And it seems, I think, that role of supervision might be very important, because in schools and community clinics, therapists have that ongoing time when they can really think through what they're doing in their setting. Whereas teachers, even though they have some support from a behavior consultant or an autism specialist coming into their special ed classroom, it's much more catch as catch can. And so it was interesting to see that finding in your amazing data from the other study, because we think that might be important, that real key time to talk about what you're doing. And I think that some of the leaders on our team were the supervisors that were doing that supervision, and the behavior specialists in the schools. And so we could see that difference in how they were going to find extra time to support their teachers versus in the supervision, that time was already set. And that was one thing. The other thing is the use of rewards and promotion is much, I'm not going to say much more flexible like in business, but more flexible in community clinics. And then in schools where things are very tied to really rigid practices in terms of when teachers can get promotions or how that works, it was easier for leaders in community clinics to tie that to an evidence-based practice use than in school. So those two areas I think are important. We're still really looking into that, but those are the ideas that we've come up with so far.
That's great. Bruce and Kimberly, I want to give you a chance to add to that if you want, or just sort of reflect on that. And after you do that, let me just ask you this other question. Do you think your system might work in places that are not particularly experienced with the use of research evidence?
Well, I'll do the reflection first, and then I can let Kim maybe speak to the site differences that we didn't show you. But just back to this idea of, do individual differences matter, or do kind of professional preferences and attitudes and climate? Those things do matter, but they seem to disappear when we put a really compelling appliance into the context. So a quick metaphor here: if you think of evidence-based treatments as sort of paper maps, right? And that's kind of been the structure for the last 20 years of trying to implement evidence. It's like you pick off one of hundreds of possible things, and then you try to use it. And we've known for many years people find it cumbersome, so we study why don't people use things that are cumbersome. Maps are hard to fold, that you can't see out the windshield, right? And we do a lot of research on how to get people to use them better. If you put GPS in the car, all the individual differences about who pulls over and stops for directions, who looks at the map before they drive instead of while they drive, most of that stuff goes away, and you see this tremendous uniformity of behavior. And I bring up GPS because a proper appliance should give you not just one page of the map, but the entire evidence base of every possible geographic, every street you might go down and every mistake you might make. And it's self-correcting, and it gives you just what you want and so forth. So, we're really coming at this from the perspective that, and I guess what I want to say is, like, what I've gotten the most out of from research practice partnerships is not how we've changed our community partners, but it's how they've taught us to change how we think about the things that we're building. The evidence products we're building are paper maps, and they're not working, and we need to do better. And so, so it's not that, again, it's not that those individual kind of climate and personal attitudes and preferences about evidence don't matter. But if we can build the right thing, they matter a lot less, if that makes any sense. And Kim, I'll let you speak to the site differences if you want to talk about that.
Yeah, thanks. So I have 2 points to make, I think, with regard to site differences. I mean, I did mention that, we chose these 2 sites because of differences in resources and their prior experience with using research evidence and evidence-based treatments. And what's interesting, we made one discovery along the way, which is people's experience with evidence-based treatments in mental health, for example, doesn't necessarily generalize to their experience and their use of evidence for other problems. So we had in Los Angeles people who had a lot of training in a variety of different evidence-based interventions. But when we, asked them, or when we studied their use of research evidence related to engagement, we found that people across the sites were kind of on a level playing field in a way, because they hadn't been previously exposed to research evidence specific to engagement. So that's just kind of one reflection. But where that also is relevant to the action cycle is that we did find that Los Angeles providers and supervisors kind of had a little bit of a leg up in terms of being, having some of the habits that we see within the action cycle. So they, when we look at site differences, they might be more apt to assess, consider different problems or select a practice, whereas that's not part of the typical professional repertoire of many of the providers in South Carolina, just naturally. So they kind of start at different points on this, have different starting lines, but the trajectories are very similar. Like once we introduced the CKS, we actually found growth in both providers in both conditions. So the CKS was able to elevate the kind of the use of research evidence and the action cycle completion of providers in South Carolina at a level that was pretty close to those in Los Angeles.
Yeah, so in our GPS, and this is my shout out to LA drivers, but in the control in the control group, it looks like LA folks were slightly better drivers than the folks in South Carolina. But once we put GPS in the car, everybody was doing pretty much the same. So, which is really exciting for us.
We have another question, and I will paraphrase it a little bit. I expect that probably everyone on the panel would have quite a bit to say about this. And so it's really directed to all of you, and somebody's just going to have to jump in and start. But I also want to encourage some interaction too. If you just kind of want to, reflect or build on something that another panelist has said, please do that and jump in and don't wait for me to call on you. So here's the question. We seem to have developed a strong supply of evidence across disciplines, and certainly within certain disciplines, as we've already heard, but we continue to struggle with wide-scale use of these bodies of knowledge. What are your thoughts on nurturing the demand side or incentivizing the use of evidence? Are you aware of development work or causal experiments on incentivizing evidence use?
I'd love to jump in on that first.
Please do, Adam.
That is an absolutely a crucial insight, especially for SREE and especially in education research, because the early thinking in the early 2000s was that the reason education decision makers weren't using evidence is because the evidence wasn't credible. Someone around that time wrote a book called The Awful Reputation of Education Research. And the thinking was, if we improve the supply of evidence, naturally the decision makers would gravitate to it and start using evidence in their practice. Well, we have made a lot of progress in the supply of credible evidence around education policy and practice. That is the great success story of IES and education sciences over the past 20 years, and we should take a lot of pride in it. But getting evidence used is another matter entirely, because it is exactly as this questioner describes, it is about the demand side for evidence and not just about the supply side. And here I think there is a lot of work to be done. Now, research practice partnerships are in fact a strategy to improve the demand side, because the idea is that if the research agenda is jointly constructed, then there will be greater interest in getting evidence in evidence that actually speaks to the problem that school district officials are raising. But what we've seen from work that I mentioned and work that was presented today is that school districts have limited capacity to absorb evidence because they're so busy with the day-to-day challenges they face. And of course, decision makers have challenges from many sides, not just from the lack of evidence. So, that's not the first thing they think about when they wake up in the morning. So what can we do to improve the evidence? Well, we saw today in Aubyn Stahmer's work an example of research that's explicitly designed to increase the absorptive capacity, in this case of mental health clinics or school-based mental health provision, but that could be applied to school districts or schools as learning organizations as well. There is a lot of development work being done in research around research practice partnerships that are trying to cultivate demand for evidence. The William T. Grant Foundation has a new funding opportunity that we call our Institutional Challenge Grant, which is also explicitly designed around this demand side issue. So the Institutional Challenge Grant challenges universities to develop partnerships with public agencies or nonprofit organizations to jointly develop a research agenda to build the capacity of that nonprofit or public agency partner to use evidence in its decision-making, i.e. the demand side, and to shape the incentive structure within the university to encourage partnership-oriented engaged scholarship. So these are some examples of work that is trying to build on the demand side as well as the supply side. I'll mention one other study because it had a major publication just come out in PNAS, and this is a study of the research to policy collaboration, which is a collaboration between researchers and congressional legislative offices. So this is about policy, not about practice. But again, it's about creating a structured interaction between a researcher and a decision maker that cultivates demand as well as ensures supply.
I'll jump in for a moment because Adam, I've been in conversations with you and Bruce about this, and so I'm surprised. I was waiting for you to mention social impact because the last conversation I was in with Adam and Bruce about this particular issue is that we've incentivized. We have to look at the incentives on the other side, on the supply side, and there are very strong incentives for scientists and faculty and scholars to continue to develop their own interventions. That's how people get promoted, and to push those and really to brand themselves. And Bruce has published a paper recently with colleagues that shows that interventions in mental health across time are not varying a whole lot. So we continue to produce very similar interventions. So I think we have to do something on the supply side to shape incentives a little bit differently rather than just generating. But I've heard Adam say, let's think about social impact and incentivize social impact of interventions. So that's one thought. And then my second thought is that, in the context of our study, we've really tried to focus on the design of kind of our evidence packaging, our CKS intervention. And we tried to make it easy to use and useful. And there is research from other fields that shows that these design properties are integral. So there's something about an innovation that makes it appealing to use. And if we help people work smarter in their job and it's easy to pick up, doesn't require a lot of instruction and support to use, people will naturally use it. And I bet Bruce would like to say something after all of that too.
Well, yeah, I was going to reference that same literature, that engineering literature. There's two reasons people use things. They have to be easy and have an on-ramp, and they have to have high utility. And you can give people a gift card for using research evidence, but it's actually not as important to them as, did it actually solve the problem that I'm facing, right? And is that conspicuous and so forth? We do okay on the utility side. Most of the evidence-based things do work. The problem is on the ease of use and the on-ramp side. And as Adam alluded to earlier, it's managing the economy of attention that, people warned us 50 years ago. Herb Simon warned us 50 years ago this was going to be a problem. The information age. We have more treatments than we can use. We have more facts. We do not have a shortage of knowing what to do. The problem is, how do we distill that down, filter out all the noise and everything that's irrelevant, and deliver just what we need, make it easy, and make the utility conspicuous. This is going to be easy to do, and it's going to solve my problem. And on the rewarding side, we're a fan of rewards. What Kim was referring to when she said, like, structuring the social ecology, that supervision interaction was almost like a game doing a crossword puzzle together. Like, you take turns walking through the action cycle. People don't even know they're walking through the action cycle, but they're just kind of doing this activity we made. And it's fun. And it would be really awkward, socially awkward, to like step out of that flow, because there's this nice kind of naturally reinforcing interaction between people. And so we're leveraging those really immediate proximal. People love to get a smile from their supervisor, right? And have this back and forth, as opposed to having these sort of external incentives, these policy incentives, or our district's going to get more of this or more of that. We're really a big fan of like making it work right there in the moment and making it reinforcing and feel good to use as you're doing it.
And I'll just jump in and say, we talked about generalization across sites. This exact same conversation can happen at autism research, where we've got lots of intervention with tons of overlap, branded interventions, and people are trying to say, we don't need to worry about the brand, but it's also very hard to provide a training in an unbranded intervention, right? So this is a challenge. And if we ask teachers, why are you using a practice? They will say, it is because it works with this child in my classroom, not because someone gave me a gift card or because of the literature. They really want to make a difference and make an impact. And so I think that is really key of figuring out what those key things people need to learn are. And just as Bruce and Kim were saying, delivering it in a way that makes sense and is easy to use, especially, at least for me, it's really relevant in special education, where many of our providers are paraprofessional who change their location often and need just some key things that they can implement to support those students and teachers. So the gift cards are great, and the most important thing is they're making a difference for the kids.
Excellent. Okay, I wanted to pick up on a question from Rachel Cole that I think also sort of reflects back on something that Kimberly mentioned, and thanks for this question, Rachel. What changes would panelists say are needed in the research production process to support the use of research evidence? And I think I might expand that also to say to support learning about the use of research evidence. Kimberly, would you like to start since you brought up that topic?
I'll say a brief thing. I guess, one thought is that we are very focused, like in mental health interventions research, as a field, we're focused on the clinical procedures, by and large, that people are doing in the context of a therapy session with the youth. And there are a lot of other treatment-related decisions that we don't pay attention to. And so to me, I think one thing that might be specific to our field, I'm not quite sure if it generalizes to education, but we need to be thinking about decisions more broadly rather than just about practices. So it is about think about what is the problem and what are the possible solutions that we can use to solve that problem. Is this child getting better? And how do we measure outcomes and all of these other decisions? And I think there's some small pockets of researchers studying some of those questions more broadly. But as a field, we are very focused on the treatment, which I think contributes to the mass production of many different interventions.
I just want to say, if you're sitting here in the listening to the webinar and so forth, and you're near pencil and paper, write down the word ontologies, because when we talk about what developers should be doing on the supply side, it really, we have more than 1,200 randomized trials in mental health, and there's like another 150 a year that get published. There's no way to stay on top of the literature. And what ontologies are about is applying a structured, agreed upon set of constructs and their relationships that can say, we can take this entire literature and within seconds filter down exactly what you need. So think of it as, instead of picking interventions from this massive literature, picking facts from the literature. So it's a different way of sourcing evidence, right? We give me all the evidence base, just give me the facts from the evidence base. Don't give me a single intervention. And as Aubyn pointed out, that's not easy to do. The National Academies of Science is investing heavily now in trying to promote the use of ontologies in intervention development and behavioral science more generally. I think we're about to see it in the next 10 to 15 years, a major revolution in intervention design that moves away from this proliferation of many, many instances of interventions to a collection of facts that is searchable. That's the vision. And I think, when I tell my graduate students, if you're going to do intervention design, you need to learn about ontologies.
I think that's a great point. In autism research, I think one of our big challenges, and the reason community partnered research is so important, is that sometimes the research with the least evidence is the best package, right? It's got the best GPS system. And the researchers, when presenting about their intervention or strategies, are very tentative about when it works and how it works, whereas people who have a nice package are much less tentative about their results. And that is much more appealing because it's simpler to implement and can work, and the complexities are not as well articulated. And so I think researchers need those community partners to help them with how to share the facts in ways that are receivable by the people who are going to use them. When we did our intervention manual, and every single example our team came up with, our community partners said, no, thank you. And they ended up writing all the treatment examples in the manual, which made it much more usable. And there are sections that we felt we needed to write in terms of research evidence that we ended up putting in later chapters that I'm sure no one has ever opened, but made us feel better. And so I think that community partnership is really important so that the facts that work get to the people who need them.
I think we have time just for one more quick question and quick response. We have two questions that are really around scaling. And one from Bethany Miller is, really around who would be the ideal actors, including funders, to support building the required ingredients that we've talked about, like evidence syntheses, absorptive capacity, training on evidence use. What's the ideal role of private philanthropy in comparison to government for scaling up evidence use?
Well, I'd love to jump in on that one too. I have a position on that, which is private philanthropy is no substitute for government funding. IES spends about $200 million a year on supporting research. The William T. Grant Foundation spends about $13 million a year on supporting research. The Spencer Foundation spends about $20 or $25 million a year. So our ability is dwarfed by the ability of federal fund, and that's not to mention NIMH, which has been Aubyn Stahmer's major funder, and Bruce and Kimberly have had other government funders. We are best thought of, private funders like the William T. Grant Foundation and the Spencer Foundation are best thought of as catalysts, are best thought of as ways to demonstrate, or opportunities, sources to demonstrate the power of a certain approach to research. And unless it's picked up by government funding opportunities, it's never going to reach the scale that it needs to. So IES did fund 2 knowledge mobilization centers during an earlier round. I hope IES will continue to do more of this, and I hope we'll see more knowledge mobilization coming out of NIH as well. I see the role of private funders as catalysts and supporters of demonstration, and it needs to be picked up by government in order to achieve scale.
I want to echo that. And William T. Grant is a fantastic catalyst, small and incredibly effective. But the role of government can't be understated. And I guess one thought I have about this in terms of scaling is think of it as industrialization of use of evidence. And at least in mental health, we are still kind of in the, if you use agriculture as a metaphor, we're still in sort of the roadside farm stand phase where literally the farmer sells the products out of the back of the truck, by the road kind of thing. And if we think of evidence as the food supply, right, we want to get evidence everywhere. Industrializing takes mobilizing highly specialized and differentiated pieces of industry as well. And so, right now I see the government facilitating more research. But I do think at some point, and this is something I feel pretty passionate about, I think at some point we need to see a stimulation of industry, of building evidence appliances, building the kinds of structures that last and are sustainable in communities that don't depend simply on the farmer to sell the food, so to speak. And until we see that coming, I don't think we're really going to scale. I don't think intervention developers really know what it means to have market share. Most of us have less than 1% of market share, even the most successful among us. And the other reason I mention this is because I think if we don't, from the research government side, incentivize that industrialization, I think there will be industries that move into the attention of economy, managing the facts, managing the information, misinformation space in mental health that might not be the industries we want, so to speak, if you know what I'm referring to. So there can be some big companies that are going to move into behavioral health spaces, and we don't necessarily want them controlling the dialogue and controlling the filters. So that's my thought on that.
Well, that sounds like an excellent last word to have. I want to thank our distinguished panelists. There has been so much that you've said that we can take away that I think is probably providing very new perspectives and also sort of practical insights about ways to study use of research evidence. I also really love the metaphors, the evidence gift cards, the farm stand phase, the industrialization, the evidence appliances. I've got a whole new lingo to go away with as well. So thank you very much. Thank you for the questions. Adam, I just want to see if there's any last word that you would like to give about your grant competition.
Yes, thanks. If people will scroll up in the chat, you'll find the link to our use of research evidence grants competition. We would love to see more research, especially research looking at robust strategies to get evidence used, like the presentations we heard today.
Thank you so much. And don't forget about the networking session, which begins now. If you go right back to the sort of main conference page and you look at the agenda and then look at today's date, you'll find a place to click into that. It's just a place to gather and, talk about continue the conversation that we've just been having. So thank you so much for joining and have a wonderful afternoon.